Hi everyone, and welcome to our module on opportunistic fungal infections. So you can break fungal infections down into three general categories. There are the fungal pneumonias, there are the fungal skin infections, and then finally there are the opportunistic fungi infections. And that's what we'll talk about in this module. And these fungi include Candida, Aspergillus, Cryptococcus and Mucormycosis, and finally Pneumocystis. Candida is part of the normal flora of human beings. You can find it in the mouth and intestine, you can find it in the skin and the vagina. And one thing that's high yield for step one and also very clinically relevant for your third year rotations is that Candida is a common contaminant of sputum culture. So there is no such thing as Candida pneumonia. And if you send a sputum culture in a patient with pneumonia to the lab and it comes back positive for Candida, that is not the cause of the lung infection. That is a contaminant and it's normal flora of the mouth and the esophagus. The way Candida makes people sick is that it overgrows when it shouldn't. So if it overgrows in the mouth, you can get oral thrush. If you get Candida overgrowth in the esophagus, you can get esophagitis. There's normally some Candida in the esophagus, but if you get too much, it'll give you esophagitis. When you get Candida overgrowth in the vagina, especially in women who've been on antibiotics, that's called vulvovaginitis, or many women just call it a yeast infection. And then sometimes babies get a diaper rash, which can be caused by Candida. Candida can also disseminate, especially if you are severely ill or immunocompromised. And when Candida disseminates and gets into the bloodstream, it can be a rare cause of endocarditis, and it can disseminate to almost any organ. This is called candidemia when it gets into the bloodstream, and disseminated candidiasis can affect almost anywhere potentially. Candida is a dimorphic fungus, so it can exist as a single-celled yeast or as a mycelium with hyphae. But really what you need to remember about Candida is that it likes to form two unique shapes, and these are very high yield for you to remember for your boards. The first unique shape that Candida likes to form is that of the pseudohyphae. These are elongated budding yeast cells, and it's easiest to understand this with a picture. So imagine that you have a circular yeast cell and it buds off another circular yeast cell, but imagine that they stay attached and then begin to elongate. Well, you could get two elongated yeast cells like this with a constriction between them, but it's not really a septate, it's just a constriction, and that is a pseudohyphae. It looks like a long branch, it looks sort of like a hyphae, but it is not a hyphae. It's not two separate cells with a septa between them. It is two yeast cells that are stretched out with a narrowing between them. That's what a pseudohyphae is. In addition to pseudohyphae, Candida likes to form germ tubes, and this is the basis of a test for Candida called the germ tube test. So what you do is if you have a lesion that's suspicious for Candida, you take a little bit of a scraping of it and you put it in a tube and you heat it and incubate it at about 35 degrees for a few hours. And if it's Candida, what will happen is that the yeast will sprout hyphae. Those are called germ tubes, and that's what it looks like down here in this picture. These are germ tubes, so these are the yeast cells here, and these hyphae are sprouting out of them. And when you see these germ tubes start to form after you take it out of the incubator, you know you're dealing with Candida, and that's how you can test for it in the laboratory. So this is a zoomed in picture of what I showed on the last slide to demonstrate pseudohyphae. And what you can see here is in the top right corner, you've got circular yeast cells, and then in the middle and the bottom of the slide, you've got these long branches here. And usually you will not see yeast cells and branching hyphae together on one slide. If you think about all the specimen slides we've looked at for the fungal pneumonias and ones we'll look at later for Aspergillus and other, generally you see either hyphae or yeast, but not both. When you see both present in one slide, then you are most likely looking at Candida because you're not really seeing hyphae, you're actually seeing pseudohyphae, which are budding yeast. Very unusual for hyphae and yeast cells to exist at the same time in the same environment. As I mentioned before, Candida can cause a number of overgrowth diseases, so let's talk about these in a little more detail. The first one is oral thrush. This is a picture of it right here. It's a white plaque that grows on the tongue or the buccal mucosa or the back of the pharynx, and it's caused because the Candida, which is normally present there, has begun to overgrow. The classic patient to develop this is an asthma patient who's taking inhaled steroids and not using the steroid inhaler properly, and it's getting on their tongue and their mouth, and they're becoming relatively immunocompromised, and thus the Candida can overgrow. Thrush is also a common presentation for patients with HIV. They don't know they have HIV, and then they present to their doctor with thrush. So if you see a board question and the question stem states the patient is sexually active and now has thrush, you should think of HIV. Patients who have HIV and AIDS can get Candida overgrowth in their esophagus, and this is called esophagitis. They will have a white pseudomembrane when you take a look in their esophagus with a scope. That's called an EGD. Women get what's called a yeast infection. This is vulvovaginitis caused by Candida overgrowth in the vagina. These women will have itching and discharge, and the discharge is classically described as cottage cheese in appearance. And the classic woman to get this is someone who has taken an antibiotics. This decreases the normal flora in the vagina and allows the candida to overgrow. And then finally, babies will sometimes get a diaper rash. There are many causes of diaper rash, including just irritation of the skin, but one cause is candida, the fungal infection, and these babies will have beefy red plaques with satellite papules in the region covered by their diaper. Candida is a very rare cause of endocarditis. This is almost always in an IV drug user who gets the candida into their bloodstream. And then finally, patients who get candidemia, which is candida in the bloodstream for any reason, including IV drug use, can have disseminated candidiasis, which can spread to any organ system. So let's talk about which patients are at risk for candidemia. Candidemia happens to patients who are immunosuppressed. Candidemia is a major problem in patients who are neutropenic from chemo, especially patients in the hospital getting bone marrow transplants. They receive very high-dose chemo and become severely immunocompromised. Patients who are critically ill in the ICU can get candidemia. This is very common. Patients who have central lines are at increased risk. The central line can be a source of the candida in the bloodstream. Any patient receiving IV nutrition, which is called total parenteral nutrition or hyperalimentation, is at increased risk. The nutrients that are delivered directly into the venous system increase the risk of candida and allow candida to thrive. And then finally, as I mentioned before, IV drug users are at risk for candidemia and can get candida endocarditis. The treatment of candidiasis depends on where the infection occurs. Women who have vulval vaginitis or babies with diaper rash can be treated with a topical azole. A single dose of fluconazole is sometimes given to treat yeast infection in women. Oral thrush is classically treated with the nystatin swish and swallow. Nystatin is an antifungal drug that works just like amphotericin B, but it's toxic if given systemically, so its main use is topical or the swish and swallow for thrush. You can also use fluconazole to treat thrush. People with esophagitis are treated with fluconazole, and there are resistant cases where more aggressive antifungal agents are used, like voriconazole and caspofungin. And then finally, candidemia and endocarditis is usually treated with a potent antifungal agent like caspofungin or amphotericin B. You can sometimes use fluconazole if the patient's stable and not immunocompromised. There's a rare genetic mutation called chronic mucocutaneous candidiasis. This is a genetic mutation in autoimmune regulator genes called AIR genes. As a result of these mutations, these babies are born with T-cell dysfunction, and they can't react to candida antigens normally. As a result, they get chronic skin, mucous membrane, and candidal infection. So the way this will present in a board question is a child who has recurrent thrush and diaper rash, and they're probably going to ask you something about either the AIR genes or the T-cells, which are dysfunctional. You should be aware that different cells of the immune system play different roles in defending us against candida infections. T cells, it turns out, are very important for mucosal defense. As evidence of this, HIV patients often get oral thrush when they have low CD4 counts. On the other hand, neutrophils are the most important cells for systemic defense, and as evidence of this, HIV patients rarely get candidemia because their neutrophils are intact. In addition, you rarely see candidemia in chronic mucocutaneous candidiasis. On the other hand, chemo patients often get candidemia. They are neutropenic and they are at great risk for candida bloodstream infections, and candidemia is a major problem on bone marrow transplant units. And I've put a nice review article down here at the bottom of the screen if you want to read more about all the evidence of how T cells play an important role against mucosal defense against candida. Next, let's talk about Aspergillus. So Aspergillus is a fungus that's found everywhere in nature. It's ubiquitous. There are a number of different subspecies that cause infection. There's fumigatus, flavus, and terreus. And generally the way you get sick from Aspergillus is by inhaling the spores or the conidia. And in order to get sick from Aspergillus in general, you need to have some type of immunocompromise. It generally does not cause disease in people who are healthy and well. And a classic patient to get sick from Aspergillus, especially in the hospital, one that you're likely to see on rotations, are patients receiving high-dose chemotherapy, especially for stem cell transplants. Aspergillus is a major pathogen that causes morbidity and lots of mortality among patients who undergo stem cell transplants. A couple of features of Aspergillus that it's high yield to remember. First of all, it is a fungi that has the catalase enzyme. It is catalase positive. This means it's a common pathogen in chronic granulomatous disease. This is a rare condition where people are at great risk for infection from catalase positive organisms. It's a monomorphic fungi. It does not form yeast cells, so if you ever see a biopsy slide in a board question with small circular yeast, you are not looking at Aspergillus. It forms branching septated hyphae, so it likes to form hyphae at branches that look like V's. We'll see some picture in a minute. But I always remember that the A in Aspergillus is like an upside down V, and that reminds me that it forms these V-shaped branches. And you can usually see septa in the hyphae, so especially on board questions, they're most likely going to show you hyphae where you can visibly see the divisions made by the septae. And then finally, the tips of some hyphae grow spores. These are called conidiophores, and this is how the spores get in nature, and they later get inhaled and cause disease. So here's a picture of an Aspergillus hyphae with a conidiophore on the end, and these little dots are little spores that it's going to release. Down here in the bottom right is a picture of some of the hyphae, and you can see that the branches always look like V's. All the branches look like V's. If you see lots of irregular branching and they don't all look like V's, then you're looking at some other fungus, probably mucormycosis. And then up here in the top right, I've zoomed in just so you can see that there are septae right here that you can visualize easily. And in pictures of Aspergillus and board questions, you're almost certainly going to be able to see those septated hyphae. Aspergillus causes 4 diseases that you need to know about. The first one is aspergillosis, and this is the classic severe pneumonia that happens to patients who are neutropenic. We'll talk more about that in a minute. Aspergillus can also cause a condition called allergic bronchopulmonary aspergillosis. This is an allergic reaction to the fungi that happens in patients who have cystic fibrosis or asthma. Aspergillus can invade preformed lung cavities, classically cavities created by tuberculosis, and form a fungus ball. This is called an aspergilloma. And then finally, Aspergillus makes a toxin that's strongly associated with hepatocellular carcinoma. It's called an aflatoxin. We'll talk about that in a minute. So first, let's talk about aspergillosis. This is a very severe lung disease, and the classic case is a neutropenic patient receiving chemotherapy who develops fever and cough. There will be pleuritic chest pain, there will be hemoptysis, and there are many findings on X-ray. You can see nodules and densities and infiltrates, but definitely the X-ray will be markedly abnormal. The fungi can disseminate to any organ, so it can spread to the bloodstream and get to the heart and cause endocarditis. It can get to the brain and cause abscesses and mycotic aneurysms, which are aneurysms caused by the fungi. And there are 3 treatments that can be used to cover aspergillosis in this type of situation. You can use voriconazole. That is the only azole that covers aspergillosis. You can also use caspofungin, which is an echinocandin, or you can use amphotericin B. Allergic bronchopulmonary aspergillosis, or ABPA, is a hypersensitivity reaction to aspergillus. What happens in patients with this condition is the lungs become colonized with aspergillus, and this occurs primarily in people who have some type of defect in their lung function. So it typically happens to people who have asthma or cystic fibrosis. And there are some classic findings of ABPA that are high yield to know for your board. So when they look at the lymph tissue in patients who have ABPA, they find increased numbers of Th2-CD4 cells. And these cells synthesize interleukins like IL-4 and IL-5. And you should know that IL-4 and IL-5 are 2 of the interleukins classically created by Th2 cells, and they are synthesized in this condition of ABPA. These interleukins then stimulate eosinophilia, and they stimulate the production of Ig antibodies. And these 2 are classic findings in patients who have ABPA. So make sure you know the immunology of this, because it's a nice tie-in between microbiology and immunology that board examiners like to ask you about. So the classic case is a patient who has either asthma or cystic fibrosis and has recurrent episodes of cough, fever, and malaise. During these episodes, there may also be mucus plugs and hemoptysis. The peripheral blood examination is going to show eosinophilia, and there are going to be high levels of IgE detected. You can diagnose this by skin testing for aspergillosis, and you can treat it with steroids. And especially on step 1, they are most likely going to describe a case like this and then ask you something about the Th2-CD4 cells and the interleukins that they secrete. The next aspergillus disease is an aspergilloma, which is a fungus ball caused by Aspergillus fumigatus. Aspergillus fumigatus likes to grow in preformed cavities. Pulmonary tuberculosis is the most common association, so often this is someone who previously had tuberculosis and had left behind a cavity in the upper lobe, and the aspergillus gets inside and begins to grow. These fungus balls are actually often asymptomatic and detected on routine imaging or imaging of the chest done for another reason, but sometimes they can cause hemoptysis. You diagnose it often just by imaging in the classic patient, or you do a sputum culture. And sometimes these are just observed if they're asymptomatic, but if you do want to remove the fungus ball, it'll require surgery. There is a toxin produced by aspergillus that's associated with hepatocellular carcinoma. It's called aflatoxin, and this toxin can contaminate corn and soybean and peanuts. Remember that aspergillus is found ubiquitously in nature, So it can produce this toxin and it can get into these types of foods. And if you eat a lot of foods that are contaminated with aflatoxin, you can get hepatocellular carcinoma. Now, industrialized countries like the United States screen for aflatoxin and they don't allow foods to be sold that contain the toxin. But patients can get exposed if they eat lots of food from non-industrialized countries, or maybe they emigrated from a non-industrialized country where this toxin got into the food, or people that eat lots of locally grown foods that may be contaminated and aren't screened. The next fungi is Cryptococcus neoformans, and this fungi exists only as a yeast. It's like the opposite of aspergillosis. You are never going to see hyphae coming from Cryptococcus. And one thing that's high yield to know about it is that it has a very thick capsule, which is relatively unique among fungi. Its main disease it causes is meningitis, and this is only going to occur in people who have HIV/AIDS or people who are immunocompromised from chemotherapy or post-organ transplant. Cryptococcus is found in the soil, and it's also found in pigeon droppings, and people inhale the yeast, which then goes to the lungs and the bloodstream and gets to the meninges. It can very rarely cause pneumonia. There are reports of cryptococcal pneumonia, and it can rarely spread to other tissues. But as I said before, the most important disease to know about is meningitis. A couple of high-yield items to know about Cryptococcus. The first is that it can be cultured on Sabaros agar, and Sabaros agar is a growth medium used for yeast and fungi, and the classic pathogen to grow on it is Cryptococcus. Another thing to know is that India ink staining of Cryptococcus samples will show capsules with halos. So this is an example of that down here. So India ink is a negative stain. It makes the background dark so that the yeast stand out. And you can see that all these little circles have these halos around them, and those halos are caused by the capsule present in Cryptococcus. Another thing to know is that there is a test for Cryptococcus called a latex agglutination test. So in this test, you mix a sample with latex beads that are coated with an antibody to detect capsular antigen. So if the capsular antigen is present, meaning if the sample contains Cryptococcus, the latex beads will clump together. That's called agglutination. So when you mix a sample with these latex beads, if they clump together, it means there is presence of the Cryptococcus capsular antigen. And this is another way of detecting the presence of that capsule. Remember, the capsule in Cryptococcus is very high yield to know about. It's something they like to ask you about on step 1. Patients with cryptococcal meningitis have indolent symptoms that develop over weeks, symptoms like fever and headache. And this is very different from bacterial meningitis, which has acute symptoms that develop rapidly over a few days. Cryptococcal meningitis classically raises the pressure inside the brain and the skull. The ICP can get very high, and in fact there is a risk of herniation when you do a lumbar puncture or a spinal tap, so you must do some type of imaging before you do the spinal tap to see if there's evidence of hydrocephalus and increased ICP. The treatment for cryptococcal meningitis is either amphotericin B, and you sometimes add flucytosine to it. The main use of flucytosine is by adding it to ampho B for treatment of cryptococcal meningitis. You can also use fluconazole, and sometimes intrathecal therapy is used, and they like you to know about this for step 1. Sometimes you need to directly administer the antifungal agents into the cerebral spinal fluid in the spinal canal. Next, let's talk about the condition mucormycosis. This is a very rare fungal infection of the nose, eyes, and brain, and it's caused by 2 types of fungi. The first one is called mucor, and that's easy to remember because it's in the name of the disease. The other one is called rhizopus. And both of these fungi have an important enzyme called ketone reductase, and so as you can imagine, this means they thrive in environments where there's high glucose and ketoacidosis present. So the serum from patients with DKA has actually been shown to stimulate growth of these fungi. So you can imagine that risk factors for mucormycosis include diabetes, especially diabetic ketoacidosis. It can also happen in other patients who are immunocompromised, like patients on steroids, patients with leukemia, and patients receiving stem cell transplants. But the classic condition to cause mucormycosis is diabetic ketoacidosis. You get disease when you inhale the spores and then it enters the nose and the alveoli. It is called an angio-invasive fungi, which means it invades the vessel walls. It classically starts at the sinuses and then spreads to adjacent structures. So Aspergillus likes to go to the lungs and cause pneumonia, but what mucormycosis infections do is they often start in the sinuses and involve the nose and the eyes and the brain more than the lungs. Patients with mucormycosis get severe sinusitis, fever, discharge, congestion, sinus pain. If you ever see something like this happening in a patient with DKA, especially in a board question, you should think of mucormycosis. There can be necrosis of the palate, so when you look in the mouth you can see dead dying tissue. There can be redness and cyanosis of the skin over the face and sinuses, and this is because the fungi is eating away the blood supply. Black eschars may be seen. Eschars are black dead dying tissue. There's often pain and swelling around the eyes. The face can get numb from damage to the cranial nerves. And then finally, mucormycosis can trigger cavernous sinus thrombosis. I talk about this in the modules on neurology, but the cavernous sinus contains several important neurological structures, and if you get a thrombosis of that sinus, you can get multiple findings in the head and neck. So the classic case is a patient with DKA who's being treated for the acidosis and then develops fever, headache, and eye pain. You diagnose it by a biopsy, and we'll see some pictures of these fungi in a minute, and the treatment is to surgically debride the infected area and use amphotericin B. So the trick to mucormycosis is differentiating it from Aspergillus under the microscope, because both fungi can infect immunocompromised people and both have hyphae. There are a couple of important distinctions, though, to help you recognize mucormycosis. Mucormycosis shows very broad hyphae, so let's look at these hyphae. They're very wide, much different than the narrow hyphae you see in Aspergillus. In addition, the branching here is irregular, so in Aspergillus you will see lots and lots of V's, lots of V-shaped branching. I wrote that on the screen for you here. In this picture down here you see irregular branching. There are some that look like V's, but there are other that almost look like a T here. It's very irregular. And then finally, mucormycosis usually shows no septations or very rare septations. And in Aspergillus, they will always show you a biopsy sample with lots of septations. So just remember that Aspergillus has that narrow, regular V-shaped branching with many septations. Mucormycosis is different, broad hyphae, irregular branching, and usually no septation seen. The last fungal infection we'll discuss is Pneumocystis jirovecii, which causes pneumocystis pneumonia, which is usually just called PCP. It's a diffuse interstitial pneumonia that requires immunocompromise. It's a classic HIV illness. It's an AIDS-defining illness. It's one of the ways people first started to present with HIV in the 1980s when the virus became prevalent. It exists only as a yeast which gets inhaled, and there's usually no symptoms if your immune system works. And the chest X-ray classically is markedly abnormal in PCP pneumonia. It shows diffuse bilateral interstitial infiltrates. Again, when HIV first came on the scene in the 1980s, healthy young homosexual men began presenting with severe pneumonias that showed a whiteout on their X-ray, and that's how I always remember what PCP pneumonia looks like. It's diagnosed by microscopy, and they like to show you these microscopy images on step 1. You can do a sputum sample or a bronchoalveolar lavage or take a biopsy, and then you send it for special stains or antibody testing. One thing that's important to know is you can't culture PCP pneumonia, so you have to identify it through some type of stain. And special stains are used, and they're usually silver, so just remember silver stains for PCP. And these are some examples of them down here. And remember, it's a yeast, so you're not going to see any hyphae. You're going to see small circles. And they use silver stains, which usually make the yeast very dark. So you can see how there are dark little circles in the lungs in this picture on the bottom right. And this is a different stain here in the bottom left, but again, it's dark little circles present in the lungs. And if you see those, you're looking at Pneumocystis jirovecii and PCP pneumonia. The first-line treatment for Pneumocystis pneumonia is Bactrim, which is TMP-SMX. This is an inhibitor of the tetrahydrofolate synthesis pathway in the fungi. You can also use Dapsone, which is not a sulfonamide, but works just like sulfonamides to inhibit tetrahydrofolate synthesis. And then finally, there's a drug that's really only used in this situation, pentamidine. It can be used inhaled in addition to through other methods, and its mechanism is not entirely clear. It was developed to treat trypanosome infections in Africa, but it has efficacy against Pneumocystis pneumonia as well. And this is probably the only time you'll ever be asked about pentamidine in a step 1 question will be for the treatment of Pneumocystis jirovecii. Prophylaxis is done in patients with HIV/AIDS, so they often put people on Bactrim when their CD4 count gets below 200 cells per microliter, because this is when they become at risk for Pneumocystis pneumonia. Many patients who take high-dose steroids or other immunosuppressant drugs are also placed on TMP-SMX, and this is also being done to decrease the risk of Pneumocystis jirovecii infection. And that concludes our module on opportunistic fungal infections.